to sell them to it. Part of people's vaccine hesitancy is that they're not being told about some of these rare events, and that gives ammunition to people who are anti-vax to sort of say, well, we weren't talked about this. I have one other question after that.
Yeah, sure. I think as you mentioned, these are only things that you can really find in post-marketing surveillance with large populations, because they're exceedingly rare. And so in most places what they do is, after the rollout, then they look at, huge population level studies, and it's usually looking at signal. I think that's the easiest way to look at things, where they look at, okay, there's a baseline of this many, and then within the vaccinated population, what is the number of people who have developed this, and then they look at that signal. Is it higher or lower than the baseline population? And that's probably the easiest way to look at things on a population scale. And it was similar with a lot of the COVID kind of adverse events following immunisations, was looking at, once it was rolled out in a population, and then that signal. Yeah.
My second very quick...
I just wonder if Michael would like to comment, given his first line professional.
So I got to join with, as per usual, smart paediatricians who are infectious disease physicians looking at the post-COVID signalling, and we went through and looked at every older event that was purportedly related to vaccination, and there were stunningly few, because you've got a complex group, unlike children, where death is not an uncommon outcome to their living. So I absolutely agree. I think it's post-marketing signalling is the only way we're ever going to find these things out.
My second very quick question is, do we push the burden of morbidity for RSV out with older children, so that I recognise, and you adequately presented it in terms of the hospitalisation rate being much higher in very young infants, but is there an issue that where if a child is protected and then it wanes, what might happen to the severity of that? So is there some sort of surveillance around that?
Yeah, I think that's a really good question, and it's something that we'll just have to see as we kind of roll out these programs. There is really good data to show that in infants that have received the monoclonal antibody, that they do get exposed to RSV because they produce their own post-F antibodies, which is not, within the nirsevimab, because all pre-fusion antibodies. And they don't have severe disease in the second year, the second season or the third season. So that is reassuring. The children that potentially, maternal antibody and then a maternal waning and then infection later, I think it's probably a similar concept in that they most likely get exposed. The issue is that once we have a large decrease in circulation and then there's no exposure during the time of protection, will that shift the disease burden to older children? We did see that in post-COVID era that it was, RSV kind of came at a bit of an odd time, and older children were more likely to be affected because they hadn't been exposed during the usual kind of phase. Same as pertussis, we've had this huge surge of pertussis because most likely they didn't have that circulation at that specific time. So it is a question that we're looking at, and looking at, okay, well, do we need interventions at later stages?
Just an added point, we don't know we haven't got enough longitudinal data in older people. We know that it's helpful out to 2 years and almost certainly beyond. We just don't know what the beyond is.
Yep. Hi, Luda Molchanoff. Immunisation clinical lead for all of regional local health networks, and this is a question for Michael and a comment. I applaud you for your input and influence across the aged care facilities. I actually presented at the INSIG symposium on Tuesday, and it was on older persons, how can we make it better? So across the six regional local health networks, we have 47 aged care facilities here in South Australia. So 10 years ago, there was no coordinated program. Now there is a coordinated program. Every single site offers flu vaccine. not all sites offer NIP vaccines. So if we bring in or introduce another vaccine, RSV, how can we make sure that this is coordinated at the state level? I mean, I know, and this is my question, because shingles is starting to come on board into our sites because it's an issue, and it was only really a lot of our sites became proactive last year in delivering the shingles vaccine. COVID is an issue because we can't access it based on what you said as well. It's the reporting as well as at the moment I'm hearing we can't even access vaccines, and this is a private facilities as well. They can't access the COVID vaccines in the regional sites. So how can we make it easier or make it better for older persons in aged care facilities? Yes, the rates may be higher than the community for flu, but what about RSV? What about shingles? What about pneumo? What about all the other vaccines that are on the NIP?
Yeah, you're going to get me started, aren't you?
Yeah, me too.
Look, I think the first point is an important point to make. I got the opportunity to be the interim chief clinical advisor for the Aged Care Quality Safety Commission, and I got a suitcase of reports dating back 14 years, over 7,000 pages. We didn't know anything new in the commission that we didn't already know. My experience has been, if you get smart people in the room, there is almost no problem you can't solve. You just don't get the smart people in the room. And the challenge I gave to the Immunisation Coalition last time I presented was, we have the smart people in the room. We just got to get together and help the government figure out what to do next, because not always, but often they're looking for opportunity to make things better. And things are better, they're just not better enough. So what can we do? Well, collaboratively we need to work together. We need to make some sort of logical things, and I agree with you. I think there are some practical problems with the way we deliver the COVID vaccines, and that they are disincentivising treatment. And you can see that to some degree by the fact that the figures for flu and the figures for COVID are so significantly different. And it's not just a timing thing, although a timing thing is a factor. And somebody stepping through can figure out pretty quickly. It's just that we don't always get the right hand and the left hand working together. So I'm going to do what I did last time and say the smart people are here, or virtually. This is where we can make a difference. We've got the leaders in the room. If there's enough political will, there is nothing we can't fix at a reasonable price. Remember, our PBAC is the envy of the world, and we know that because Mr. Trump appears not to like it. So that's a positive. But it's the one that Vietnam looked around the world and said, what can we do? Let's do the Australian PBAC because it's going to make a difference. It's going to make drugs deliverable at a reasonable cost. And yes, it might be holding up something here and there, but for the most part it's working. So get the smart people, make a difference, create the coalitions. It's our only opportunity, really.
I've got a few questions online. Maybe start with Achana.
Can we have the microphone at the front so that Robert's questions can be heard? Thanks.
So, how are you keeping track of residents that need COVID-19 boosters? It's been answered somewhat already.
So the question, we couldn't hear, Robert.
I think your microphone.
Robert. Oh, we got it. Okay. Normally I'm booming, so yeah. What do you see as the main barriers to putting RSV immunisation for older adults in the schedule, and then improve uptake? Either of you?
Cost. Yeah, it is cost. It's been submitted to the PBAC.
And I read out very quietly, so I'll be much louder now. Sound like Trump. How are you keeping track of residents that need COVID-19 boosters? How could that be better improved?
Well, I think Michael's going to tell us later on that we actually have made some significant inroads to getting better access to air from residential care, and it has been a problem. I mean, we didn't know who was immunised and who wasn't, and when you've got a turnover rate that's significant in residential care, it is difficult. And when you've got only one or two key people, they can spend their life doing all sorts of things, but but they simply haven't got enough time. So Michael and his team have made a significant difference, and when it's fully implemented, it will make a difference.
And Achana, sorry, it's hard to read. So I know there will only be a few months of data. Is there evidence that pregnant women receiving RSV vaccine are more receptive to also having another vaccine like flu vaccine?
Yeah, no, that's a really good question. Yeah, the data will come out, and the data on combination, kind of multiple vaccines will come out. Anecdotally, it seems that most people are getting it at their antenatal clinic with flu and DTP.
Great.
Robert, it's interesting that we've got a RSV vaccine that isn't funded for aged care. My question is, Australia just not a place where any vaccine that isn't PBAC and NIP, basically if the government doesn't do it, it can't be a good vaccine attitude. Is that going to be the future for, or is there a place that there's going to be good uptake maybe for private vaccines, or where people actually fund them, where it's not the government funding it?
I'll make a comment and then Michael could comment. So it's always tricky when it's not government funded because it's not at the forefront of people's minds. So you look at the immunisation schedule and you see, okay, it's very comprehensive. You have the infant program, you have the immunocompromised program, you have the older adult program, the pregnant program. And on there, it actually doesn't include non-funded vaccines. So another issue is, at the age of 50, people are recommended the DTP vaccine, but it's not funded. So it's not, again, at the forefront of people's minds. So I think that is an issue. I think it's great that we have it available and people can purchase it, but I don't think that will make universal coverage at all.
I'll soon be retiring. I'm benefiting from middle-class welfare and a good superannuation policy. But I've got elderly relatives who we are, as a family, subsidising their living. If you are at home and you are in a rental environment, not in a non-public rental environment, you are in real trouble. $280, which is what my customers tell me, is a really substantial burden. So, sure, there is some vaccine hesitancy, but at $280, that is all of their discretionary spend for more than a month. Now, for me, when the first shingles vaccine came out, of course I had it. But, the $280 was, quite frankly, somewhat irrelevant. But, with metastatic cancer. But in reality, for most of my clients, and where my hospital borders on West Heidelberg, which is a fairly impoverished environment, they simply cannot afford it.
One more question.
Hello, Sarah Pitts from Monash Health in Melbourne. I'm with the Specialist Immunisation Service there for patients, and we look after our 4 residential care facilities that are run by Monash Health as well in regards to their immunisation provision. We have been providing pneumococcal, shingles, flu and COVID for our residents over the last couple of years. And have seen an amazing uptake with our residential care, residents. Arexvy has actually just been provided by the Victorian Government for all public residential care peoples over the age of 60 for Victoria a couple of weeks ago. I suppose my concern is if we are unable to provide, our services are unique, if you like, within a public health system, that we have specialist immunisation nurses and aged care nurses that work together to provide immunisations for our very vulnerable residents. I suppose my concern is if we can't increase Shingrix, pneumococcal, COVID and flu for our residents, how are we going to get RSV out to our residents as well?
Yeah, I think it's tricky,
And all we're doing is perpetuating disadvantage. I mean, if you're in the wrong place, and you can substitute Monash for rural and remote or Indigenous or yet some other disadvantaged group, or a group that with poor linguistic skills or English skills, or people who are otherwise marginalised, or the list just goes on and on. We're doing some great things and we are capable of great things. It's just that we don't seem to do the great things consistently, and who the hell knows why.
John, you can have a third question. You can't have two.
I gave everybody else an opportunity. Michael, one of the problems with RSV is there are a huge number of issues that can contribute to under-ascertainment. Clinicians learned about bronchiolitis, they don't hear about RSV. We've only recently started monitoring it. It looks a lot like typical UTIs, or the ERTs, and only a small group get very unwell. The PCR is unreliable because the respiratory load is low in that group. The window of opportunity is small. So some people estimate that it's actually under-ascertained by 3 to 5-fold. One strategy that might help, and I don't know if it could be implemented across the country, but Michael's here and could tell us about that. If every emergency department with any older person that came in, not just with respiratory symptoms, but confusion and other things, did a multiplex PCR on admission, then they have a much better idea about these other viruses. And while some of them can't be readily treated, then you could actually have a policy of isolating, so you don't have a multiplier effect in that environment or send them back to another situation. So that would be, it might have to have more than just the PCR, but that's imperfect. But if that was a policy, in terms of a clinical pathway, that we could actually detect those more effectively, then that might have an impact on both the hospital environment and also sending them back to residential care.
The problem is you're too smart. You're absolutely right, and I absolutely agree with you, but the point I was trying to make before is the system is so fragile and somewhat broken. That's why in subacute care, with even some great IPC people, in the wrong environment, it spreads like wildfire. Everything spreads. And look what happened. I've now got my 4th ward with norovirus. Now, in an ideal world, you'd have to say, well, Michael, you must be, quite frankly, incompetent. How can you possibly have norovirus spreading, or how can you have flu spreading, or how can you have COVID spreading? And the staff are infected. How many are from work and how many are from home is a different matter. But I absolutely agree with you. Against that, we've also got a very strong push to keep older people out of hospitals for very good reasons, but also because the geriatricians are a little bit paranoid. We've got this view that maybe older people don't deserve to come to hospital and they should be managed somewhere else. And there's a sort of a prevailing intensivist type view that older people shouldn't access substantial supports. So it's a really difficult ethical problem, but many of my patients now, I've got acute at home, acute in the residential care, GM in the nursing home. I keep on coming up with more acronyms, and they're all designed to manage people outside the place. So my access to all sorts of the things that would be in a sensible and convenient access to, multiplex PCRs, etc., is more and more problematic in the model that we're doing to try and protect the system from basically falling over all the time. So this is the problem that we run into when sensible practice gets modified by emergent need.